everyone. My name is KiiraPynno and I'm a radiation therapist here at Tampere University Hospital, Finland. I've been working with AlignRT for around 1 year now. And today in this presentation, we aim to present to you AlignRT workflow here at our hospital and the role of postural setup in breath hold treatments and extremities. And we'll show you the use of postural setup in practice using a live subject. And moreover, we'll give some latest results of setup accuracy with AlignRT Advance in DIBH. Okay, a little bit more about our content for today. At first, I'll give you some background information of our AlignRT use here at Tampere University Hospital. Next, I'll show you what kind of research we've done so far with the AlignRT. Then I'll give you some feedback from our users concerning advanced version and how it has improved the workflow. Then I'll discuss shortly how did the advanced version update, how it went here at our hospital, and after that we'll go into our main topic, which is the postural setup in AlignRT and the role of it in the setup workflow. We'll show you a short video clip of our setup workflow in DIBH and extremity. One of our radiation therapists was kind enough to act as a volunteer patient in the video. Finally, I'll give you some results about advanced DIBH setup. Okay, some background information. We're placed here at the Department of Radiotherapy in Tampere University Hospital, Finland, and we have 43 radiation therapists working here in Tampere, and in a day about 130 patients are treated with 6 variant Linux, 2 of which are TrueBeam STX, 2 basic TrueBeams, and 2 older IX Linux. AlignRT system is installed on one of the regular TrueBeams. We also have another surface-guided radiation therapy system, Catalyst, on the other TrueBeam, and RPM or RGSC are in use for DIBH treatments with the other 4 Linux and 2 CTs. We use visual coaching for all DIBH CT scans and treatments. We've been using AlignRT since the beginning of the year 2017. And especially with the new advanced version, the rotation of the therapists is going really smoothly. Around 30 radiation therapists at the moment can use this system. With the AlignRT, the day begins at 7:45 a.m. and ends at around 8:30 p.m. At the moment, all patients except for, or pretty much all patients except for head and neck patients are treated with AlignRT and positioned also. And we feel that the more we use the system, the more comfortable we are using it and confident also, because you need to kind of get used to the system because it's so different from the tattoo guided or positioned radiation therapy. And we started using the AlignRT Advanced 6.2 version in June 2020. And next, some words about it from our perspective. From the beginning of the 2017, when the AlignRT was first installed here at our hospital, we've done several clinical studies to improve our OsteoRT DIBH workflow. And the goal has been to improve the patient setup accuracy, but at the same time to evaluate the possibilities to make setup workflow more practical and the treatment itself less time consuming. We've one published study concerning the N0 DIBH, where we noticed the SGRT could be a way to reduce the amount of imaging, KV imaging, and as we noticed that the accuracy of the tangential image, the ribs, placement of the ribs were is excellent even without IGRT, if we have good surfaces for the setup. And this finding was in line with several presentations in the SGRT meetings and published studies. Still, we found out that the errors in the pitch and vertebra in longitudinal direction, which have more significance when the lymph nodes are treated. And we have 4 ongoing SGRT studies at the moment, and 3 of those concern DIBH with breast and lymph nodes or mastectomy, and 1 concerns the region of interests of the free breathing breast group. Those studies have given us valuable information for improving our setup on workflow, and hopefully we can publish them in the near future. Okay, and to shortly name some advanced version improvements, which have made our workflow easier. In the previous version, importing the patient was behind several stages and thereby time-consuming. Now with the advanced, it takes around 2 minutes in total to prepare the patient for the treatment in AlignRT. And in the import phase, for example, we need to select the protocol, as you can see in the image. If I can show you with the mouse here, you just have to pick the protocol and the plan name. Very simple, simple indeed. Okay. To position the extremities and, for example, the arm in breast treatments, we used to use the treatment capture in the older AlignRT version. It takes a snapshot of the patient and compares it to the reference. And we considered it slightly clumsy because you had to correct the arm position and then take a treatment capture and continue this until you're happy with the result. And it can be time-consuming, well, slightly, but with this new AlignRT Advance, we have the possibility to use this postural setup, and both patient posture and deltas are visible at real time, which makes the setup process much easier. And based on our ongoing image guidance study, the accuracy of the postural video setup for the arm setup in DIBH is on the same level as in a treatment capture. So not much difference there, but still much smoother to use this postural setup than treatment capture. Okay, so for DIBH treatments, we only take the breath hold CT here at our hospital, Tampere University Hospital, and the reason for this is that we have 5 clinics without AlignRT, and at that time point we don't know on which clinic the patient will be assigned to. So moreover, we found out that the free breathing CT surface isn't accurate enough for us in guiding the patient to a correct initial position, and this results in incorrect breath hold level. The downside of that is we don't have the free breath setup. Reference surface on the first fraction. Therefore, the free breath setup has to be created on the first fraction on the clinic, and after the correct position has been verified with the KV images. In the previous version, we needed to draw the free breath region of interest on the first fraction. But now with the AlignRT Advanced, the region of interest is propagated automatically as we take the free breath reference surface under the BH DICOM and rename it as free breath and preparation workspace. This is much faster and more practical, of course. By choosing the setup surface only, it ensures that we can't accidentally treat the breath hold patient using the free breath reference. And here you can see in the image, setup surface only. And if you're wondering about the plan name, it's shortened Finnish. It means right breast with lymph nodes and a booster, if someone was wondering. Okay, and also some pros versus cons with the old and advanced. Before it wasn't possible to remove DICOM surface from the treatment view when we wanted to replace it with a new reference surface, and we needed some paper lists on the Linux so that we could remember which surface was in use with a certain patient, and we're also trying to be a paper-free hospital, and this made it much more difficult. But luckily, with the advance, we can easily deactivate the DICOM CT SIM surface when needed and only leave the currently used free breath and breath hold surfaces active. This is very handy, and we also have image examples here. Here are the old version, confusing old version, and the lovely clear new version. Okay, so the AlignRT Advanced 6.2 was installed here at our hospital in summer 2020, June 2020, and in the middle of COVID-19 restrictions. And it was the first installation in the Nordic countries. We had a couple of work trainings with the AlignRT trainer Katja Lano here at our hospital for around 10 radiation therapists. And after that, during the first 2 days after the update, Katja and our physicist Antti Aula were with the users to train them in practice and to see that everything goes well. From then on, we've trained the next users here, and now about 30 radiation therapists know how to use this system well. And the AlignRT system is used in the day shift and the night or evening shift, and the rotation of the users goes well with the advanced, clearly better than with the previous version, so that's a positive outcome. And it can also be noted that the with a successful update such as this has been, it can have a remarkable effect on the attitudes and self-confidence to begin to use the system, and we've really noticed that one here at our department. From the beginning, users at our department noticed that the new version is a big improvement, and I've already mentioned aspects which have enhanced our practice, but here are a few other examples of the improvements we value here at our department. There are less mouse clicks in general, which makes the system easier to use. The features which are less frequently needed are hidden in the sidebar on the treatment view, and only the main functions are visible, and this makes the general view clearer. The system opens quicker, which enables smoother workflow and is user-friendly for the person who comes to warm up the machines in the morning. If the system freezes and it has to be restarted, it's easier to keep one's cool since the rebooting of the system takes less time. And finally, we have to mention the very informative AlignRT Advanced User Guide. It was easy to collect the main things into our own internal instructions, and everything in this guide is demonstrated with images and step-by-step workflow. Yeah, we measured the time used for the setup with AlignRT and with Tattoo setup to compare these two. AlignRT setup for the DIBH is slightly more time-consuming than Tattoo setup, but and RPM. But then again, this is because of the roll, pitch, and arm position can be adjusted more precisely, and the amount of images can be reduced due to the improved positioning and isocenter accuracy of the patient. In another main group of patients, the pelvis, the time used was similar in both groups. With the Align Advanced 6.2, the postural setup and 3D photo became available. And with postural setup, the user can set up the patient using outlines generated from the reference surface and a live video stream of the patient. And this is a completely new feature in AlignRT, and we found it very practical and useful. With the 3D photo, the user can apply a 3D photorealistic view to the treatment or reference surface. This feature is visible on the right side image. We haven't made use of this 3D option as much, but then again, it is used sometimes. And 3D photo visualizes brows and other body hair quite in detail, so it might be useful for drawing the region of interest if we used open masks for head and neck patients, which we don't at our hospital. And the view of the patient seems, of course, more realistic on the screen. I'll continue with the postural setup in AlignRT. The video postural setup feature provides a real-time view of the patient's overall alignment relative to their reference position, originally from the DICOM CT sim. It's also possible to acquire a new reference surface while in video mode. And the outlines of the patient for the new reference surface are then displayed, and is seen here on the slide top right, the outlines of the patient. Visibility of the arm can be improved by acquiring a new reference surface, since the CT scan typically ends just above the chin in breast RT, and with video postural setup, the whole arm is visible, at least from the shoulder to the elbow, if new reference surface is acquired. We felt this very practical in the arm setup and also the extremity setup. The patient can be viewed in live video mode from 3 different camera pods from 3 different angles, and this of course improves the accuracy in the setup. And some things to remember according to the user guide of the Vision RT while using postural setup. And of course, reference surface should be selected, and the gantry or KV imagers shouldn't be in the way of the pods while looking at the postural setup or using the postural setup or taking new surfaces. Room brightness should be adequate, and no clothing or etc. should be on the area of interest placed there, blocking some view. Now we'll see the use of postural setup in practice. In this video, our radiation therapist set up our volunteer patient to an extremity setup. We used indexed headrest and acquired couch values. The patient is set up to a vacuum fixation, and radiation therapists check the CT markings in couch lateral at 0. Then the couch is driven to previously acquired values. Okay, and then there they go. Next, the AlignRT switched on in video view. Small adjustments are done to the patient posture, to rotation, roll, and pitch based on video and deltas. Small adjustment to isosensor is done with send to couch feature, which is happening soon. There. And video view is checked with all 3 pods. After that, KV imaging is performed and small couch shifts are done. And we acquire new reference surface for the treatment this session only. And the whole process is accurate and practical. One thing to remember, that the vacuum fixation shouldn't cover the extremity from all sides. This might block the pods. With this video, we demonstrate our workflow of the positioning of the DIBH patient. The patient lies on the Sabilla board, breastboard, which we've noticed as a good fixation with tilt and with the possibility of various individual adjustments. We verify the initial straightness with 2 tattoo marks. Then the couch is driven to the acquired couch values. AlignRT is switched on. First, we try to get the rotation, pitch, and roll to as close to 0 as possible. Then if there is need to adjust the vertical, because the patient might tense their shoulders or their head isn't correctly in place, we'll do it by correcting the posture of the patient, not by changing the vertical or shifting the couch, since there's a risk to shift the vertebra out of its correct location and thereby falsely modify the correct breath hold level in the images. With the video feature, with 2 cameras, we verify the posture of the arm and breast, which are outside of the typical T-shaped region of interest. And here at our department, we use an inverse T-shaped region of interest because we found it to correlate the best with the bony structures and correct breath hold level. With the live video feature, it's fast and accurate to check the locations outside the region of interests. We want to set up both arms correctly, since this may otherwise affect our centrally based region of interest. Sorry, using half Finnish here. After both deltas and video seem satisfactory, we move on to the breath hold surface view, and the patient is asked to hold their breath. With the help of the video, we follow how the breath hold is repeated and whether the patient might be lifting their back, for example, while performing their breath hold. And the goal is to have the patient reach the reference surface as well as possible, and preferably with repeatability. And in practice, when the patient takes the breath hold, small couch shifts are done with the center couch feature. And we don't shift the vertical, as I mentioned before, with DIBH patients, because we found that the fixed and acquired couch vertical verified with the lateral KV images guides the vertebra better than the free breath reference surface alone. Correct position of the vertebra is essential for reaching the correct breath hold level and posture. When needed, errors in the sternum vertical are corrected with new breath hold surface, with asking the patient to take more or less air into their lungs. Typically, since the SGRT guided patient setup is so accurate, we verify the correct position with only a large tangential image, KV image, without online couch shifts. In this tangential image, we see the shoulder joint, breast, chest wall, and vertebra to verify that also the N+ PTV is treated correctly. And overall position is verified with weekly orthogonal isocenter images, so anterior, posterior, and lateral. And if we have a so-called problematic patient who has difficulties, for example, repeating the breath hold with same form, they're imaged, of course, more often to ensure proper treatment. Okay, here we have fresh results with the AlignRT Advance. When looking at the most commonly used matching locations in orthogonal images, which are ribs and the sternum, we can see that the residual random errors are small in 3 directions, even without image guidance. This is because random error is only up to 2.1 millimeters in the longitudinal direction. If systematic errors are observed, new reference surfaces may be needed to minimize them. With Advance, in the latest results, the repeatability of the position of the shoulder joint and the TH1 and 2 vertebra, the bony areas which correlate with the lymph node areas. Please see the top image, the gray image. In N+ DIBH treatments, it seems also promising if systematic errors are corrected during the first fractions and new reference surfaces for the setup are acquired when needed. This allows us to verify the position of those structures with a large tangential KD image, as you can see in this green and red image. This saves time and radiation dose. Based on the studies in Tampere University Hospital, it takes on average 4 minutes less time to take and analyze only daily tangential image than to analyze all anterior, posterior, and lateral and tangential images, as is typically done with RPM. This is a remarkable time save, really, in our busy schedule. Finally, to summarize this all, the postural setup tool enables evaluation and correction of the patient posture already during the setup process. The preliminary setup results in the clinical study are promising. The postural setup gives valuable information about breath hold level accuracy, arm position, breast position, and bolus setup, to name a few examples. And in general, users are very satisfied after the update to version 6.2 AlignRT Advanced. Maybe one thing that we would like to see in the future version is to have a possibility to adjust the reference surface position or offset. This would give more possibilities to correct small systematic errors also in breath hold level and remain using the DICOM reference surface. Okay, I guess that's all, and I thank you all for taking your time to listen to this presentation and hope you got something out of it. Okay, bye.